I will start again. Thank you. I'm sorry I was on mute. I'd like to echo Nancy's welcome to all of you. It's good to be together as we learn more about this roadmap to acute care management, and in particular, supporting individuals living with dementia. Acute care is a level of healthcare in which a patient is treated for a brief illness. I'm sorry. Can we go back, or are we? Yeah, there we go. Thank you. It's acute care is a level of healthcare in which a patient is treated for a brief but severe episode of illness for conditions that are a result of a disease or trauma enduring recovery from surgery. Acute care is often performed in a hospital setting. Next slide. Who are we? We are the Massachusetts Alzheimer's Disease Research Center, known as MADRC, and it has been at the forefront of dementia research, treatment, and care since 1984, and is funded by the National Institute on Aging, that you might hear referred to as the NIA. What we do here, our teams at Mass General Brigham work together to lead cutting-edge research, provide professional and community research resources and education. And our goal is to find effective treatments and eventually a cure for Alzheimer's disease and other related dementias. Next slide. We're here to help. There are resources. Again, if you go to www.madrc.org, you'll hear us mention that numerous times throughout the presentation. And you'll find resources to help with Alzheimer's disease and related dementias, clinical trials and observational studies. And there's information there for family and caregiver support. And there's education and resources such as a program like today. And these, the Massachusetts Alzheimer's Disease Research Center reaches across Mass General Brigham, and Mass General Hospital, and Brigham and Women's Hospital. And you'll see at Brigham and Women's Hospital, there's the Center for Brain-Mind Medicine, the Center for Alzheimer's Treatment and Research, and there are social workers services and Renew support group services available if you go on the website also. Over at Mass General, there's the Memory Disorders Unit and other related clinics and research units like FTD, vascular dementia, and dementia with Lewy bodies, and Parkinson's disease with dementia. There's the Alzheimer's Clinical and Translational Research Unit, which is another clinical trial arm. There's the Sperling Johnson Imaging Labs and observational studies. And again, there's social work services available and the Dementia Care Collaborative. Next slide, please. As part of the Alzheimer's Disease Research Center, the Outreach, Recruitment, and Engagement Corps, known as the OR team, aims to offer education to the community by providing educational events and programs with partner organizations, collaborations with faith-based communities, and resource information for people in the community. But also there's education offered to professionals via collaborations in primary care physician and specialty practices, diagnostic support, educational programs for professionals, and a rapid diagnostic clinic. Next slide, please. So just to tell you a little bit about my personal investment in this, when my husband, Steve, was diagnosed at age 59 with younger onset Alzheimer's disease, we decided to face the disease head on and make the most of our time we had left together. We love the Cheryl Strayed quote that you don't have a right to the card you believe you should have been dealt. You have an obligation to play the hell out of the ones you're holding. So we educated ourselves, attended support groups, became advocates on state and federal levels for public policy related to Alzheimer's and other dementias. We remained socially engaged and shared our story generously with hope of helping others while learning from others. Steve wanted to help in finding a solution for the next generation, so he invested himself in research. And all of this is to say, we felt we had done our homework and we're as well educated about Alzheimer's and what to expect as we could be. And that was until the day when Steve was in the late stages of Alzheimer's and we needed to go to the emergency room. It was a harrowing experience, to say the least. I felt that they would have knowledge about people with late stage dementia. It was an experience that I will never forget. Steve and I would have greatly benefited from the information compiled in this roadmap education program and in the booklet that you will get. It is my hope that having this roadmap to acute care management will help save others from a similar experience in the emergency room as ours. Next, please. Navigating acute care emergencies. An emergency is an unplanned event that can happen at any time. Healthcare crisis can include infection, flu, pneumonia, diabetic complications, stroke, dehydration, trauma, and psychiatric emergencies. It's important to understand that illness and healthcare management becomes more complicated to manage with age and with cognitive decline. Next slide, please. It's good if you can avoid chaotic environments. And let me tell you, an emergency room or urgent care facility is unsettling. Noisy medical equipment and emergency vehicles, staff in protective clothing, and individuals performing multiple health evaluations can be overstimulating for an individual living with dementia. I'd like to turn this over to a medical professional now and have Linda go through some information with you.
Thank you, Judy. So how to navigate in trying to avoid the emergency room, if possible. If a medical condition is worsening, contact your doctor, your primary care provider right away, and let them know it's your preference to avoid emergency treatment, if possible, and that you'd like to get an appointment, potentially an urgent appointment. So advocating for a plan that will avoid the emergency room, asking for an urgent office visit appointment. Urgent care is busy, but often not as busy as the emergency room. So that potentially could be another option. Asking for a referral for a home health nurse to make a visit. If it's something that's like an exacerbation of a chronic illness, say someone has like congestive heart failure and they're more short of breath, potentially a home health nurse could come out, make a visit, assess the person and decide whether, they needed medication changes. At least it could potentially avoid an emergency room visit. And then some hospitals have hospital at home programs. I know at UMass Memorial, we have one. There is one at Mass General Brigham. Some of them are limited in scope and by geography. And sometimes they require a visit to the emergency room, but then you can be enrolled in this hospital at home program. And they provide intravenous, x-rays, ultrasounds, a lot of the care that you would ordinarily receive in the hospital, but receiving it at home might be better for somebody who's living with dementia. Next slide. So when you make the call, explain what's going on. If your doctor's not available to take the call, sometimes you end up talking to, it could be the medical secretary or a medical assistant, but try to get their attention and let them know that you need guidance and this is an urgent situation. If they tell you they'll call you back, ask for a time limit. Say, that's fine, but I need a call back within an hour because this is more of an urgent situation. And tell them their preference is to try to avoid the emergency room if possible and ask them to help you do this. Next slide. So just a few tips for talking to the doctor's office. Stay calm, speak slowly and clearly, state the medical situation and why it requires urgent follow-up, and give as much information as you can to the staff person answering. If you can speak with a medical assistant or a nurse, it's sometimes better. and explain why you feel that going to the emergency room is not a good idea, and remind the staff that the person has a dementia diagnosis. You might have to be persistent. You might have to stay on the phone or make several calls, but be patient and make sure they get all the information that they need. And then be flexible. If they offer you to squeeze you in for an urgent visit appointment, be open to this. If your own primary care person can't see you, maybe a nurse practitioner or a PA may be available to fit you in for a visit. Next slide. And be prepared with medical information. It's good to have all of this laid out ahead of time. The diagnosis, medications, emergency contacts, physician numbers. It's the more information that you have available, it's going to make the medical team's job easier in supporting you. Next slide. So there's a form that a colleague of ours, Janet Moore, developed. She was a nursing professor at the Elms with her students, and it's called the Admit Me form. There's a link to it, and it's also in the roadmap booklet. But I'll show you the next slide has just some information just regarding, what's your hospital of choice, emergency contacts, primary provider, just medical conditions and medications, name of pharmacy. But then on the next page, next slide, this is some really good information that's useful for emergency staff, hospital staff, or any setting that the person is going to, because it talks about how they best communicate. Do they have any assistive devices? What is their personal care like? What do they need assistance with? The behaviors that could potentially be a problem, and then also maybe triggers to this. Maybe it's trying to have the person shower, or if they're being approached in a certain way, as well as calming techniques, things that help like music, or maybe a robotic animal or something that provides some comfort for them. Favorite conversations, activities, interests, and hobbies, nutritional preferences. So this is really good information for hospital staff to have and would be much appreciated. Excuse me. So if the emergency room is not avoidable, and sometimes that's the case, if somebody falls or somebody's really acutely ill, try to give them a heads up. So the physician's office can call. I know at our hospital, we have something called Care Connect. So if I'm sending someone to the hospital, I call Care Connect and tell them the person's coming in. I give them all the information. And I ask them to highlight if the person does have a dementia diagnosis so that people know that coming in. And you can also ask to talk to the triage nurse, because it would be useful for them to know that information as well. And then ask them to have the emergency room, maybe potentially have someone meet you. That's not always possible, especially if it's busy, but it's good for them to have a heads up. Next slide. I just wanted to highlight one case that I had. That was a gentleman who was living at home with his wife. He had moderate stage Alzheimer's disease. He became acutely ill, and his wife called 911 to have him transferred to the hospital. When the EMTs arrived, he was sitting in a chair with his t-shirt on, and he became very upset and agitated about leaving with the EMTs. And his wife realized that he never left the house without a shirt and tie. He was very much a gentleman, and this was what was upsetting him. Unfortunately, it was a chaotic situation. The EMTs are used to kind of charging in and taking charge of the situation. And sometimes it's a little too much for people. And so his wife just felt that if they had just allowed that 5 minutes to at least have him put a shirt on, maybe his tie, he may have left willingly. But instead, things went badly. He was restrained. He had to have an injection to calm him down. So she actually had asked me to share this story because she felt like things could have gone better if everybody kind of took a step back and thought about maybe the best way to approach this. Next slide, please. In terms of traveling to the emergency room, it's really not advisable for a caregiver to drive alone with the person. Really ask a family member or friend to drive you so that you can give your full attention to the person who's not feeling well. And it may be unavoidable to go by ambulance. And some paramedics and EMTs have received additional training on how to care for people with dementia and how to approach people with dementia. The Alzheimer Association does a 2-hour training for paramedics and EMTs, but not all of them have had this training. And so they may not be as familiar. So it's important when they come in to remind them the person has dementia. This might be the best way to approach them. This would be, something that they should take with them when they go, and provide as much information as you can, as quickly as you can, and try to stay calm, because that will help the person who is going to the emergency room maybe remain calm as well. Next slide. And on arrival, don't leave the patient alone. It's important to ask the emergency room staff to allow a family member to always remain with the person. This was very difficult during COVID. People weren't able to do this, and the situation didn't always go well. Now I think most people have recognized that it's important to have a caregiver there. Also, when the person who has dementia may not be able to provide an accurate history, they may not be able to recall the information that is discussed with them. They may become disoriented because the surroundings aren't familiar. So it's always important to have someone who they know with them. There's another helpful form that's good to have and discuss ahead of time called the MOLST Form. And some people might be familiar with this. It's called Medical Orders for Life-Sustaining Treatment. It's a bright pink form, and it offers ways to communicate an individual's decisions about life-sustaining treatments on an easily recognizable form. All healthcare providers know this form. It goes between settings, and it's honored by healthcare providers who follow medical orders. So it's a pink form. So the next slide shows the front page of this form that talks about CPR, ventilation, whether or not a person wants to be transferred to the hospital, so intubation and ventilation. And then the flip side of that is talks about dialysis, artificial nutrition, intravenous or non-invasive ventilation. So this is something that's really helpful to discuss ahead of time so that people's wishes are honored. And if you were going to the emergency room and you had one of these forms filled out, you would want to bring it with you. Next slide, please. So Judy's going to give you some tips about supporting people.
Yeah, supporting people with dementia while you're waiting for a long period can be challenging, as I can attest to, because we were not seen for 6 hours after arrival at the emergency room, and then we're in the emergency room for 4 days. So here's some of the suggestions that we've come up with is to try to find a comfortable spot, chair, couch, or stretcher upon arrival. Locate the restrooms and try not to wait to the last minute if that's possible. And you want to provide verbal reminders of why you're making this medical visit and reassure the patient that the healthcare team and the strangers are there to help. And I would find that Steve would go off of my kind of calmness or angst, as Linda had mentioned before. And then you want to ask healthcare staff if it would be possible to wait in a quiet area, possibly other than the general waiting area, such as an open evaluation bay. That's not always available, but it's worth the ask. When you're in a bay, try to close the curtains, dim the lights, and use distraction methods while waiting. I tried while we were there in the emergency room to show Steve, I had my iPad with us to show pictures of our grandchildren on a scrolling screen to try to help him stay calm. And then again, as Linda mentioned, do not leave the person with dementia alone. Life is confusing enough when you have dementia, and then imagine being put into this busy setting, how confusing it can be. Next slide, please. This still in supporting people with dementia during long waiting period. Ask a nurse or assistant to sit with them if the caregiver needs to go to the bathroom or cafeteria. You might think it's going to be a quick run over to the restroom, and you get there and there's a line, or, you don't know how long it's going to be. So please have someone there if you don't have a family member. Also advise staff that decreasing stimulation will help keep patient with dementia calm, and provide ongoing comfort in both verbal and nonverbal ways. A warm blanket, a pillow, a smile, touching their hand or shoulder, trying to make eye contact to keep them connected with you and feeling that they're based at home within your gaze, and continuously explain that things will be okay and this is just a temporary situation. Lie if you have to, even if it's not going to be temporary. But also bring a comfort item from home to the hospital, such as a virtual pet or a doll. But like I said, I used our iPad, or a favorite blanket that can help calm them when stressed or upset. Next slide, and I'll turn it back over to Linda.
So one thing that sometimes can happen when someone's admitted to the hospital is a condition called delirium. Another name for this is acute confusional state. There's other names as well. One that, is a toxic metabolic encephalopathy. A physician colleague, friend of mine calls it acute brain failure. Just like you have heart failure, the brain just gets overwhelmed. So it's more common in hospitalized elders, and there's an increased risk among those with dementia. So about 30% of people who are admitted in the hospital either come in with it or develop it during the hospitalization. And it's characterized by a few things. One is that it's an acute change in their mental status, and the course is fluctuating. So they may be alert and talking to you one minute, and the next minute they're more confused or lethargic. And the acute change part, often the caregiver is key in identifying this. When a family member says to me, "This is not my mother or my husband," then I know that this is an acute change from their baseline. The other characterization is inattention. So they can be very distracted. It's hard to keep them, they won't follow any directions, or it's very difficult to maintain their attention. So those first two, acute change in mental status and inattention, are two characteristics that are diagnostic for them, for delirium. The last two, you can have one or the other. So disorganized thinking or altered level of consciousness. And there are two types of delirium. There's hypoactive delirium and hyperactive delirium. Hyperactive delirium would be more someone who is kind of crawling out of their skin. They're restless. They're trying to climb out of bed. You cannot distract them. Hypoactive delirium is more when someone is lethargic or not responding to stimuli as much. It's not that they're comatose. They're arousable, but and that's a more dangerous situation actually, because sometimes it's under-recognized. So there are things that can cause delirium. So some of the precipitating factors are certain medicines, especially psychoactive medicines like sedative hypnotics, benzodiazepines, certain opioids, narcotics can cause it, surgery, anesthesia, high pain levels or untreated pain, anemia, infection, or acute illness. Next slide. So the treatment of delirium is often looking for the reversible causes. So they need a thorough history, physical exam, and neurological exam, lab tests, looking through their medications. So as I mentioned, sometimes medications can be one of the causes, and then treating the underlying condition. So they might need a medicine stopped or adjusted, treating their pain. But environment's also important. And so a room should be well lit during the day and dark and quiet at night. And that doesn't always happen in the hospital, but I think we're trying to, people know how important sleep is, and sleep can actually, lack of sleep can actually contribute to delirium. So, limiting noise in the hallway, keeping the rooms dark, not interrupting for vital signs at night if it's not necessary. So these are some of the things that hospitals are trying to do to try to help promote sleep. Making sure eyeglasses and hearing aids are available. You can say someone's distracted, but if they can't hear you, then it may be that they're just not hearing you and they're not really distracted. So allowing them to have the sensory inputs that they need, and optimizing that. Family involvement should be encouraged. Monitoring bowel and bladder function. Sometimes people have difficulty finding the bathroom, or have increased episodes of accidents when they're in the hospital. Constipation can contribute to someone having more confusion in the hospital. And you want to optimize things like nutrition, so encouraging fluids and helping with eating. And then, unfortunately, when people are in the hospital, many times they're put to bed and they end up staying in bed because people are trying to avoid falls. But sometimes that can cause weakness and deconditioning. So you really want to, if possible, get the person up and moving. And that's helpful if someone is restless or just, needs to walk. And then using things like clocks, calendars, whiteboards to help orient. Next slide. And Judy's going to talk about some hospital tips.
Yeah, for the dementia caregivers who are usually pretty exhausted by the time you end up at the hospital. So here's a list of things that are suggested. Limit questions asked of the person with dementia, as they may not be able to answer correctly. Talk with the doctor outside the patient's room when possible. Help staff understand the person's functioning and behavior while at home. Again, it's great if you can do some of these things outside of the earshot of the patient. Ask your family members and friends, or hire a caregiver to stay with the person with dementia as much as possible. I needed to run home at night to shower, so my daughter would come and spend a few hours with my husband when he was in the ER. Let the medical staff know if the person with dementia suddenly seems to act or behave different, or if medical issues worsen. Ask a friend or family member to be an advocate for you, to make calls and or emails to keep others informed about the patient's progress. One thing that I did also, I would use my voice memo on my phone when the doctors would come in to talk, so I could shoot that off to my children without having to repeat the conversation in front of Steve. Help staff fill out menu requests, and be sure to open food containers and ensure the person with dementia is eating. Provide reminders to drink fluids and offer them frequently. Make frequent trips to the bathroom and assume the person with dementia will have trouble finding the bathroom on their own. Assess for difficulties using a call button, bed adjustment buttons, and the phone. These all seem like such simple things, but if you think about these ahead of time and implement them, it really can be so helpful for the caregiver. Next slide, please. And then support the caregiver. The caregiver must take care of themselves. Easier said than done, but it should be a mantra to keep at the forefront of your thoughts. Get help. Ask for help from other family members and develop a family plan. And then what we hope you do from this program today, that it will help you to talk about a trip to the hospital in advance of an emergency and have a plan and have these tips on hand. Next slide, and Linda will take over.
So if anxiety or agitation occurs, and no one likes to be in a hospital, whether you have dementia or not, but there may be a drive to go home. So try to put personal clothes out of the way so that the person's not trying to either pack up or get dressed or try to leave. Post reminder cues, especially labeling things like the bathroom door, minimizing background noise to prevent overstimulation, which is challenging in a hospital environment, and offer reassurance, a comforting touch, make eye contact, repeat answers to questions when needed. Next slide. Distraction is often good. Sometimes some hospitals have volunteers who are trained to do some of these things, to provide music or activities and or read to the person, praying, singing, reminiscing, whatever works. I had one patient who her family knew that she loved Judge Judy, and for some reason Judge Judy got her to calm down. They would just put Judge Judy on a streaming video, and it was remarkable. So whatever works for the person is and that you can relay that to the hospital staff, that's very helpful. Slow down, try not to rush the person, and then communicate with the hospital staff about other medicine changes, that some of these new medicines could be contributing to worsening confusion. Next slide. And managing pain. Be on the lookout for symptoms of pain that the person might not be verbally expressing. So maybe they're grimacing or furrowing their brow or holding onto a body part. And assume that the person has pain if they had a condition like hip surgery that's normally associated with pain. And ask for a pain evaluation and treatment every 4 hours, especially if the person does exhibit some of these signs like grimacing or moaning or furrowing their brow that seem like they're in pain. Next slide. So Judy's going to talk about interacting with the hospital staff.
Yeah, so interacting with the hospital staff, we think they should remember that not every medical professional understands the basic facts about Alzheimer's disease and related dementias. And you may need to help hospital staff by suggesting the best approach to interacting with the patient with dementia and identify what causes them distress. The other thing I just wanted to mention, while we face many challenges in the emergency room, I try to remain cognizant that every person that we dealt with had left a home that morning to work their 10-hour shift, and they maybe were doing their best. And the more that I could convey to them, the better they could help us. And to lose your patience with people or to speak unkindly maybe wouldn't be the best method to better care. Next slide. Be an advocate. Remember to provide personal information on likes, dislikes, triggers, and comfort measures to staff. Offer to help with bathing, eating, or using the bathroom. Provide reminders about hearing difficulties and or other communication problems, and offer ideas to enhance communication when possible. Make staff aware of wandering and other behavioral issues and concerns to ensure safety for the patient. Advocate and ask for additional information on hospital procedures, tests, and confirm that they are necessary. Request information on eligibility for home health services and prepare for an increased level of caregiving when you leave the hospital. Sometimes you have to remember with someone with dementia that your voice has to be the only voice that they will hear in representation of your loved one. And you have to have that voice be a clear one. Linda, back over to you.
So post-hospitalization planning. Next slide. So communication is so important. And it's important to follow up with your primary doctor after a visit to the emergency room or urgent care, just so they understand what happened during the hospitalization or emergency room visit, and if additional support is needed. One thing that we worry about is rehospitalization. So in the 30 days that after hospitalization, people are at an increased risk of rehospitalization. So understanding the change in medical conditions, any red flags that you should look for, changes in medications. All those are important to know before you leave the hospital so that you can avoid another hospitalization. Again, ensuring that they're on the correct medications, that there's a plan of treatment, that post-discharge care is set up, like ongoing care and support at home, which might be VNA nurses visiting or physical therapy or occupational therapy. And then making sure that you know about medication changes, especially if there's new medicines like blood thinners or insulin or cardiac medicines or pain medicines that the caregiver is going to have to manage at home, or even treatments like dressing changes. You know, sometimes caregivers have to take on a lot when someone's discharged, and it's good to know what you're facing and what new medications that could affect their ability to take care of themselves. Next slide. So in 2018, Governor Baker signed the Mass Alzheimer's and Dementia Care Act. And this legislation did a number of things. Two of the things that it did were, one, it required all nurses, physicians, and PAs who provide care to adults in Massachusetts to complete a continuing ed program on the diagnosis, treatment, and care of patients with Alzheimer's and all dementias. It has to be completed for the renewal of their nursing license or for their recertification with the Board of Medicine. The other thing it did is it required all hospitals, Massachusetts hospitals, to develop and implement a hospital operational plan for the acute care of patients with Alzheimer's and other dementias by October 2022, which we just passed. So most hospitals should have at least a beginning of an operational plan. It was supposed to be October 2021, but because of COVID, everything got pushed back for a year. So, but that now is a plan that hospitals should have that should include recognition of dementia and or delirium in the emergency department or inpatient units, treatment of the patient while they're hospitalized, and creating a dementia-friendly environment, and appropriate care transitions and discharge planning that address the delirium, the dementia and or delirium. It's important to discuss whether you will need additional help at home so that referrals can be made before you leave the hospital. Whether you need, again, visiting nurses, additional help from potentially like a homemaker or a home health aide or physical therapy. So discussing this with the doctor, nursing staff, social workers, or case managers so they can identify resources and make referrals before you leave the hospital. So it's important to have a well-coordinated discharge plan, and so that you know what you're facing when you go home and also know what resources you can expect. Next slide. And again, advanced care planning, we talked a little bit about the MOLST, but having an advanced care plan ensures that the individual living with dementia receives the care and treatment according to their preferences. So it's even when they can no longer express themselves, but it's good to have these discussions early on so that you know what their preferences and desires are. So this is a good discussion to have with a healthcare proxy. Primary care physicians, dementia care specialists, social workers, other health staff can assist caregivers in having these discussions. And just a reminder, we talked about the MOLST form. There's a link here that you could print it out, complete it online, and share it with your healthcare provider. It has to be co-signed by a healthcare provider as well. And have this form included with all your medical information. It can be scanned into the chart. You know, we have Epic at UMass. I think Mass General Brigham has Epic. We scan the MOLST form right into the chart. But at home, you can keep it on your refrigerator to have easy access for medical personnel. Judy's going to talk about additional resources.
Yeah, just listed here, we have additional resources. And these links will be in your roadmap information that you get also. The NIA, the Alzheimer's Association, the Alzheimer's Foundation of America, and AARP. Next slide. References here. Again, yep. So we just want to really, really encourage you to stay connected with us. Go to our website, MADRC.org. There's fantastic resources there for patients, caregivers, and there's information about the research, the cutting edge research that's being done at the Massachusetts Alzheimer's Disease Research Center. And if you can't find what you're looking for there, reach out to one of either Nancy or Lenore, who will put their email addresses in the chat afterwards, and stay connected with us. Yeah. And we would really welcome questions now. We're grateful that you're with us today.